Hey everyone. So today we're going to start our discussion of the application of specific strategies that we've been learning about over the last several lectures to specific disorders. And this is where the empirically based treatment part of it comes in. Because what people often do is they take the CBT strategies and then they kind of put them together in a manualized type of fashion to address specific disorders. And we'll be going through some of those today, and those are what you're going to be reading about in your Barlow textbook. The first topic that we're going to be talking about generally is anxiety disorders, and there are many disorders under this kind of umbrella. But I wanted to touch on anxiety disorders first and foremost because this is often what you're going to come across when working with various patient populations, as these disorders are very highly prevalent in the population. I think we can all relate to anxiety disorders because we all have symptoms of anxiety to some degree or another. While we might not have full-blown OCD, we do have certain things we obsess about and certain compulsions that we have. It doesn't necessarily meet diagnostic criteria. While we might not have GAD, we all have things that we worry about excessively. While we may not have social phobia, we do have situations in which we feel uncomfortable. And we all definitely probably have some sort of fears. It may not be to the extent that it's a specific phobia, but we do across the board see that many of people experience these types of things. So here are the specific breakdowns for lifetime prevalences and 12-month prevalences for men and women. But then when you look across the board, about 1/4 of the population will have experienced some sort of lifetime anxiety disorder, and this is meeting DSM criteria. The anxiety disorders are more prevalent among females than males, and that could be a reporting bias, or it could be that it's generally some sort of relationship between hormones or some gender-specific issue related to anxiety. So the first anxiety disorder we're going to talk about is social phobia. So it typically has an early onset with about age 14 for girls and 16 for boys. And once it develops, it kind of has a chronic and unremitting course until people seek treatment. And this is not just like I do not like public speaking, which very few of us actually do, but this is to the point where it's interfering in your daily life. So you have to think of the DSM criteria for interference in daily functioning. This doesn't mean that somebody who does not have the interference, or that it's not a significant problem in their daily lives, cannot seek treatment for these issues. I definitely myself have benefited from different strategies in coping with feelings of stress and anxiety. I think we all can. Just for someone to seek treatment doesn't necessarily mean they have to have the diagnosis. But these treatments are designed for people who have symptoms as severe as meeting diagnostic criteria. So some typical thoughts that you'll hear from people who have social anxiety disorder are, what I said sounds stupid, I'm boring, I'm going to make a fool of myself, they don't like me, they'll see I'm anxious, I won't have anything to say, and I'll blush, tremble, shake, sweat, lose control. These are all things that we say to ourselves, but for people with social anxiety disorder, these become more severe and they become debilitating, and they prevent them from engaging in many types of social interactions. So in order to have social phobia, as I mentioned, you have to have a significant interference in work and social functioning. And in some cases, it results in an inability to work, attend school, socialize, and marry are some of the kind of things that we're seeing in clinical samples. So, you may see kids who can't get their degree because they have to take a public speaking course in order to get their degree, and they can't do it, and therefore they never graduate. Most common co-occurring anxiety disorders or social anxiety are among alcoholics undergoing detox, because if you look, we talk about maybe substance abuse masking some of the underlying problems, and a lot of people drink in social situations to make themselves more relaxed. And so many times that then becomes more generalized and people develop substance abuse problems. So typical feared situations for people with social anxiety disorder are public speaking, parties, pardon me, I can't speak today, meetings, authority figures, eating or drinking in public, working or writing while being observed, or making telephone calls. I personally can say that I used to be horrified of public speaking. It's still not my ultimate favorite thing to do, but I'm much more comfortable, especially when it's not a huge auditorium. Huge auditoriums still make me nervous. I have never been a great party person. Does that mean I don't have does that mean I have social phobia? No. But it means that I can definitely benefit from some of these strategies that we're going to be talking about. So the primary treatments for social phobia are cognitive behavioral group therapy, exposure, and cognitive therapy. So let's talk about CBGT first. The potential advantages of group treatment are that you learn vicariously by looking at the experiences of the other people in your class. It also helps you feel some feelings of comfort for people, hearing that other people have similar problems, because oftentimes when people have problems, they feel they're very much alone in the world. And when there are other people sharing their feelings and thoughts and they have similar ones to you, it makes you feel better. It also fosters independence in the sense that you can practice in a safer environment. You can learn through helping other people. A lot of people feel better that way. There's a public commitment, so when you say you're going to go do something, you now have the responsibility of coming back to the group and telling them how successful or unsuccessful it was, which is motivating in of itself. I know, one of the things that they say with weight loss is that or committing to an exercise regime, for example, is to do it publicly on Facebook, because then people want to know and you feel some accountability, whether there is that or not. And you also see encouragement through other people's successes. So even if you're struggling, seeing other people succeeding kind of can help you recognize that there's a possibility for you as well. So in terms of the procedural components, there's an educational component, which in many CBT-based groups, there's kind of a psychoeducation component where you explain, the theory behind social anxiety disorder and the treatment and how the treatment is going to work. You then create exposure simulations by creating a hierarchy, so each individual will create their own hierarchy, which is your blog number 4 exercise to do. You then do cognitive restructuring around some of the beliefs that we talked about earlier, so some of these things like what I say sounds stupid, I'm boring, I'm going to make a fool of myself. So you'll work on cognitive restructuring around those things. And then there'll be a lot of home-based practice skills, because social phobia is often construed as a skills deficit, but you're going to be doing self-monitoring of your anxiety as well as your thought processes, cognitive restructuring, as well as in vivo exposure. So here you're really combining the cognitive and behavioral aspects in the treatment. The systematic desensitization can be imaginal, whereby you're only imagining these situations. For people who have tremendous fear, so if it's very difficult for you, you might start with it, doing it through imagery. However, in order for it to be effective, especially with social phobia, you have to have a real situation. And in some of these groups, they actually conduct, they'll actually hire Confederates or have graduate students or undergraduate students participate as an audience, and sometimes they'll have them, pretend to be boring or pretend to be bored, so that, it helps people face their worst fear and be able to handle it. And oftentimes it's a combination of both imaginal and in vivo, so you'll start out with imagining the situation and then you'll move to in vivo situations. You're going to use your SUDS ratings to establish a hierarchy. And you usually have about 10 to 15 items on your hierarchy. So I usually use a 1 to 10 scale, with 10 being kind of a SUDS of 100, 1 being a SUDS of 10. And then you work up by kind of 10-point increments. Depending on the degree of anxiety the person is experiencing, the hierarchy can be a little bit larger with smaller increments. And it's not to say that once your hierarchy is written, it's set in stone. This can be very much a malleable process, and you can change it as you go through. And sometimes when a client kind of exposes themselves to one thing, they'll automatically go and do the next one, or they'll by accident, let's say, expose themselves to something higher on the hierarchy, or they'll feel very brave one day and do so, and therefore it's not necessary to go to the lower levels, and so you might want to then increase the complexity and have some more higher level things on the hierarchy. So here's a sample hierarchy for social phobia. So 98, be the best man at my brother's wedding. 2 is go to Christmas party for 1 hour without drinking. 3, invite friends over for dinner. Go for a job interview. 5, ask neighbor to turn down the volume of the stereo. 6, ask a question in class. 7, eat lunch with a classmate. 8, talk to a stranger on a bus. 9, talk to a friend on the telephone for 10 minutes. And 10, return an item of clothing to a department store. So you see that this person has various rankings on their SUD scales. And then they would then proceed, starting at the lowest rung at 10. In doing that activity, you would problem solve it, you'd work through it, you'd role play it if necessary. The person would go out and do it, they'd bring feedback back, and then you would go through the stages. Usually in developing a hierarchy, I usually start with number 1 and number 10 first. I then do number 5 and then fill in the blanks in between. Just to give you another example of a hierarchy, here's one for a simple phobia like a spider phobia. So on the bottom rung, you stand 10 feet from the spider cage. On the top rung, let the spider walk over your bare hand. I have to say that's not my favorite thing in the world to even imagine. And here you might even start out with imaginal situations if the fear is too great for the person. You might even start out with something like a stuffed animal or a fake spider, like a plastic spider, and then move to a real spider. And then you kind of move through things on the hierarchy slowly. This could probably be done in 1 to 2 sessions with a simple phobia. Flooding is where a person is exposed for prolonged periods of time to fear-evoking but harmless stimuli until the fear is extinguished or the SUD scores significantly decrease. So this would be like, if somebody has a fear of spiders, that there's that show, that Fear Factor show, where they kind of had people, like immersed in different things. So you'd stick them in a cage with multiple spiders, and they would just have to stay there. They would be terrorized for, a good 20 minutes. But eventually, as the spiders were creeping all over them, their SUDS levels would decrease, and therefore their fear would probably be extinguished. And so oftentimes by exposing somebody all at once to their most feared stimuli and having them stay there and not avoid the stimuli, so they have to keep their eyes open, they don't even have to describe the spiders, the feelings, eventually that phobia will be overcome very, very quickly. So, there's something to be said for just jumping right into the pool rather than wading in very slowly, because both are painful, but one you get over with very quickly and the other one can take forever. My husband is a pool wader. It takes him like 15 minutes to get into the pool, whereas I, on the other hand, will just jump in. You have to also look at your client's personality and their ability to tolerate distress when doing these kinds of things. So examples of common exposure situations that you might use in social phobia are initiating conversations, asking for a date, public speaking, writing in front of others, eating or drinking in front of others, working or playing while being observed. There's a typo there. And the problem with these situations is that in many cases you can control the situation. However, when you have people, doing these things, you can't know how other people are going to react. So you have to prepare your client that if they do a public speaking scenario, their worst fear might be coming true. Like, they might urinate themselves, they might have a panic attack, their audience might react in a very bored way or be hostile to them, or the person might, then have something that they might react negatively or say no to. So sorry I got interrupted there, but for example, if you ask somebody out on a date, you have to be prepared that the response could be no, or if you initiate a conversation, it could be that the person is not interested in talking to you and turns away. So you also have to prepare your client for those types of situations. So some of the stuff that you may, simulate with role plays in group or in individuals in therapy are assertion, interaction with authority figures, so asking your boss for a raise, talking to somebody about some unjust treatment that you've received, going for a job interview, joining an ongoing conversation, which is always challenging, I think, for anybody, making mistakes in front of other people, expressing your opinion, and revealing personal information. So depending on, what your issues are, there may be varying degrees to which these things bother you, and then you would treat them accordingly. One way to do this is through virtual reality, where you actually have simulations of people and they can react in different ways, and you're giving a speech. And another way, as I said, is that people have confederates and that they actually have a live audience, and you practice giving a speech in front of those people. And you could also have them act differently. The author of your textbook, David Barlow, has a facility in Boston where they do a lot of anxiety-related treatments, and they are kind of the state of the art when it comes to virtual reality. Not all clinics are equipped to do this, but they do a lot of work, and they do a lot of work with the Boston VA in terms of PTSD work, which we'll talk about later. So you can see here, this is a very archaic virtual reality simulation. Now they can do things that are much more sophisticated, but you can have an audience that has negative behaviors and how you feel about those, and then they can have more attentive, positive behaviors. So you also then want to try to integrate cognitive restructuring into the exposure activities, and so you can have them give their SEDS ratings at 1 minute intervals. And so while they're giving their SEDS ratings, they can say what their thoughts are, and then the rational responses to their thoughts. And so if you would have, people behaving in a negative kind of way, like they are in this scenario, you can say people are behaving disinterested, they're very bored by what I'm saying, and then the rational response would be that, they probably had a long day, they'd be bored with what anybody is saying. Or you might give a more realistic based response, is that, I'm not the most thrilling person, but at least they're still sitting in the room. You can also do strict cognitive therapy for social phobia, but that's described kind of in your textbook, and so you can kind of read that on your own. But just to go over some of the core kind of assumptions and beliefs here is that people have excessively high standards for social performance. My speech must always be perfectly fluent. I must always appear intelligent and witty. If I disagree with somebody, is a conditional belief, they'll think I'm stupid. If I appear anxious, people will think badly of me. So other core beliefs include, if others want to know me, they'll let me know, and then I'm uninteresting, different, weird, I'm unlikable, which obviously in many cases is not the case, but people have these beliefs anyway. You might use different assessment measures, and we talked about the BDI and the BAI and the BHS as common ones. If you're working specifically with people with social phobia, you might want to use measures such as a social phobia and anxiety inventory, a social behavior questionnaire, and a fear of negative evaluation questionnaire. In terms of how cognitive therapy differs from CBGT, you kind of talk about the cognitive model, you talk about safety behaviors, you'll do video and audio feedback to the individual, so you'll record them and then give them feedback. You'll shift attention to observation of others. You want to give them behavior experiments in a social setting. You deal with the anticipatory anxiety, which we all experience before we engage in some sort of exposure exercise, and how that impacts your self-image. We want to construct a more realistic self-image, and then deal with the remaining assumptions that we have of ourselves. And so I'm going to skip through some of these future slides. You can read about these in your textbook because this gets kind of long. So just some of the things that you want to identify are the safety behaviors. When you thought that the feared event was going to happen, did you do anything to try to prevent it or prevent others from noticing it? Is there anything that you do to ensure that you come across well? What do you avoid drawing attention to yourself? Do you do anything to control these symptoms? Because sometimes by having these safety behaviors, we avoid encountering the feared stimulus, and so we actually have to expose ourselves to those. What happens to your attention when you're afraid of the feared event will happen? Do you become more self-conscious? Do you have difficulty following what other people are saying or doing? And do you become less aware of other people? And so because of these situations, your world becomes very closed in, and you don't notice necessarily what's going on around you. And so as you focus your attention on yourself, what do you notice? Do you have an image of how you think you appear? Do you have an impression of how you are feeling or coming across? And when you try to conceal your symptoms, how do you feel or look to other people? So I remember, just an example of this would be, as an adolescent, when you have a pimple, which we all do in adolescence, and you look in the mirror and that thing is like the most enormous thing that you've ever seen in the world, right? Like you're magnifying very much what might be a very small blemish. And so I remember thinking that everybody's going to be staring at this pimple on my face. It's disgusting. And so I would walk around with, my hair in my face. I would put crazy amounts of concealer on it, which probably made it look much worse than it actually did. I would not look people in the eyes because I was afraid. And so by trying to conceal my symptoms, I probably actually looked much worse to other people. So then you want to try to give them experiments where they manipulate the focus of the attention onto something else. So it's 2 5-minute conversations. The first conversation, the social phobic is engaging in their safety behaviors, and the second conversation, they're not. And then they predict the extent of anxiety and how will they'll come across with and without safety behaviors. And this is then videotaped or audio taped, and then they watch it and you kind of criticize yourself. And then you rate these ratings. And so you want them to kind of drop some of these safety behaviors and shift their focus externally instead of internally. And so by using the video and audio feedback, you can see your true self, and you want to work through it with them. And so when they're discounting the accuracy of their image, if they're seeing themselves in a very different light than they actually are, that's when you work with them on addressing some of those cognitive distortions. So some of the meta-analyses that have been conducted looking at the effectiveness of some of these interventions, they divided 49 studies into 5 classes of treatment. 1 was exposure-based, 2 was cognitive therapy without exposure, 3 was cognitive therapy plus exposure, 4 was social skill screening, and 5 was a waitlist control. And the trend for cognitive therapy plus exposure to outperform the other treatments, which makes sense to me because you're exposing the person to the feared stimulus while at the same time doing cognitive restructuring. The length of treatment predicted outcome and dropouts, thus the periods that were shorter, the treatments that were shorter were better than the ones that were longer, and the effectiveness of treatment increased over the follow-up period. You're going to have to forgive me, the children are now awake, so there's a possibility that you'll be hearing some background noise as we proceed, but I will do my best. Now we're going to talk about OCD, or obsessive compulsive disorder. So there's a lifetime prevalence of 2.5% for OCD, and the disorder is slightly more common among women than men. The age of onset usually ranges from early adolescence to young adulthood, with earlier onset in males than in females. So this points to something potentially biological that's going on, and if you've ever worked with patients with OCD, you'll see that there's something qualitatively different than some of the other anxiety disorders. Not to say that it can't be treated, but there's an element of it, this irrational kind of belief that seems to be qualitatively different in my clinical opinion. So we all have obsessions and compulsions. However, people with OCD have recurrent obsessions or compulsions that are sufficiently severe because they cause marked distress in their lives. So generally the compulsions are taking up to 2 hours or 2 hours or more per day, and the obsessions are preventing them from doing things. They're very time-consuming, and they significantly interfere with the person's normal routine, occupational functioning, or usual social activities or relationships. So if you have to check the house 50 times before you can leave in the morning, and you're late for work by half an hour every day, that's significantly interfering with your work. There are different types of subtypes of OCD. There's the contamination, or the doubting, are the most common, followed by somatic, the need for symmetry, aggression, thinking you're going to hurt somebody, and sexual intrusions. Checking and washing are the most common compulsions, followed by counting, the need to confess, ordering, and hoarding. So there are different forms of obsessions. So there are thoughts, there are ideas that are experienced as unacceptable or unwanted. So the idea of stabbing my child. So for somebody who has psychotic disorders, they may have these ideas, but somebody who has OCD will have this idea, and that idea is very distressing for them because it's very incongruent with their view of themselves, and they've no desire to do that. Images, people have mental visualizations that experience as troubling, like one's elderly grandparents having sex, visualizing yourself having sex with your parents, sacrilegious things. If these things tend to sometimes have religious connotations for people that grew up in very religious households. And then you have impulses, unwanted urges or notions to behave in inappropriate ways, like to yell obscenities, which is separate from something like Tourette's syndrome, or to engage in kind of inappropriate behaviors. People might also have violence, the impulse to attack a helpless person, the image of loved ones being dismembered, or impulse to reach for a police officer's gun, which is interesting because I think we all have that impulse to a certain degree. As I walk through Penn Station in the mornings, I look at the guns of the police officers, and I think to myself how easy it would be to just kind of reach and grab one, and then the consequences of that behavior. It doesn't distress me because I know I wouldn't do it, and it doesn't consume much more than the few seconds that I spend looking at them, but I think that a lot of these things are kind of on a normal continuum where many of us have these types of thoughts or beliefs, and then it's only when it becomes dysfunctional that it's diagnosed as an obsession. Sex, people like to stare at other people's genitals, or thought what it's like to be homosexual. One of the students that I'm supervising now in the doctoral program, she is seeing a client who has a fear that other people are going to view him as homosexual, and he's heterosexual, but he's very absorbed with the thought that people think that he is homosexual, and it very much dominates. They're doing a lot of exposures related to kind of homosexuality. Blasphemy and sacrilege, so the image of Jesus with an erection on the cross, or the thought that God is dead. In terms of obsessions, their contamination ones are 55%, concerns of harming self or others 50%, sexual concerns 32%, somatic concerns 35%, and symmetry concerns 37%. So you'll see that these total more than 100%, and many people have multiple obsessions. So what is not an obsession? Worries about real life issues like work. If you're worried excessively, that can be generalized anxiety disorder, but it's not obsessive compulsive disorder. Depressive rumination, so people who are depressed tend to fixate on things, but that is only mood congruent. Repetitive sexual fantasies that are appealing, so some people just have a large sex drive, and this is something they fantasize about frequently. Jealousy, preoccupation with a new car, boyfriend, etc. We all have these obsessive moments when something new and exciting has happened to us. Or cravings to gamble, steal, or drink alcohol, because those are, while they may be similar to obsessions, those are related to the specific disorders. So mental neutralizations versus obsessions are often confused for one another. Obsessions are intrusive, unwanted thoughts that evoke anxiety or distress, and mental ritualizations are deliberate mental acts that we do to neutralize or reduce anxiety or distress. So you'll find people that have these kinds of obsessions often develop these neutralizing routines where they'll have to count to a certain number, they'll have to do different things in order to reduce the anxiety or distress that's produced by the obsessive thought. Compulsions are overt or covert responses to intrusions. They're designed to counteract the obsession and to decrease the anxiety the latter produce. So it's like a sense of having no choice. It's very time-consuming, excessive, and senseless. So many times, the person cannot, explain what they're doing or why they're doing it. They recognize that the house is not on fire, but they still have to check the gas stove 50 times. They recognize that, washing their hands, for the 50th time is not necessarily going to remove the germs. And typical compulsions are checking, washing, repeating, counting, ordering, and silent praying. The Y box is the typical gold standard assessment outcome measure for OCD. It has an obsessions and a compulsion scale, and they have different levels here. So it's similar to something like the BDI, but again designed for individuals with obsessive compulsive disorder. So when you're doing an assessment of a client with OCD, you want to make sure that you look at the content of their obsessions, both external and internal cues, and the consequences of their external and internal cues. You also want to learn about their avoidance patterns, so how do they manage to avoid the distressing things, what are their rituals, because many times these things are covert, and so unless you expressly ask them about it, you're not going to find out about a lot of the rituals that they do, or they might not be explicitly obvious to you. And you want to look at the relationship between avoidance patterns and the fear cues. Learning theory for conceptualization of OCD is that the obsessions give rise to anxiety or distress, and the compulsions are designed to reduce the obsessional anxiety. The performance of the compulsions prevents the extinction of the obsessional anxiety because the obsessions are being neutralized. Therefore, the compulsions are negatively enforced by the brief reduction of anxiety that they engender. So people have these thoughts, they become very distressing to them, and they then do this behavior. The behavior is then reinforced because the anxiety is decreased. So therefore, the theory is that making people expose themselves to their anxiety-provoking situation without engaging in the obsession will therefore reduce the anxiety and decrease the reinforcing value of the compulsive behavior. So the most common treatment for for OCD is exposure and response prevention. You can also do cognitive therapy, although my advice to you would be to do ERP first, unless it becomes very aversive to the client or there's some reason you can't do it. And people might have combined medications and ERP. Okay, that was Zachary. Zachary is now watching Super Y. So in terms of behavioral techniques, there's in vivo or situational exposure, which is gradual confrontation of situations that evoke the obsessional thoughts. So this is where you're actually, Having situations like, for example, somebody who has a fear of stabbing somebody, you would put a knife in front of them and have them kind of expose them to those feared stimuli. Or somebody that had homosexual fantasies, you would expose them to images of homosexual videos or engaging in sexual relations or something like that. You also do imaginal exposure, where their gradual confrontation of the unwanted thoughts via tapes that they have to listen to again and again, or different exercises they can do with you in session. The response prevention part of it comes from refraining from engaging in the neutralizing mental rituals, the reassurance seeking, or the thought control strategies. So somebody, for example, who is a washer, you would expose them to germs, and like such as having them, touch toilets, stick their hands in garbage cans, and then you would prevent them from washing themselves, and they would have to kind of sit with that anxiety. It's very traumatic, but as people kind of, as you have to imagine, they're doing this on a hierarchy, so they're starting out with very lower levels, or lower levels, not very low necessarily, but lower levels of anxiety, and kind of culminating in these much more high-level rituals. ERP was a treatment of choice shortly after it was developed in the 1960s. And as I mentioned, you want to establish a fear hierarchy, beginning with relatively easy items and gradually getting more difficult. And then the theory behind it is that gradual exposure to triggers, and habituation to the fear response will then neutralize some of these things, and they no longer will produce anxiety. So what happens is when you treat the anxiety-provoking situation where, like, for example, you're having them touch toilets, you very quickly see a peak of fear where they're kind of getting up to their 100 sense level. So you can imagine, even for the thought of us, sticking your hand in like a public toilet like the one at Penn Station would cause a great deal of anxiety. But as you have them sit there, repeating it over and over again, keeping the germs and like rubbing the germs all over their hands, their arms, etc., etc., therefore the anxiety decreases to a level where it's tolerable, and they're not allowed to engage in the rituals, and so therefore the anxiety becomes habituated. And that's kind of the theory behind a lot of these exposure exercises. So initially, the fear is peaked, but then you have to sit with it long enough until the fear goes down. So sometimes this might take a long time. So when you're planning your sessions, sometimes, when you're doing ERP or any kind of exposure, it may have to be longer than the traditional 45-minute session, so you have to plan for that accordingly. Especially with ERP, many times the therapist also has to do it too, to demonstrate to the client that it's okay. This can be potentially gross. I know my student that I'm supervising, what she would do is ahead of time, she would actually wipe down the toilets. So she, wouldn't be quite as gross for her, but at the same time, the client doesn't necessarily know that you did that, and their fear is more of the act of the feared germs rather than the actual germs anyway, so it doesn't matter so much. So you'll see here, this is 4 sessions of exposure therapy, and you can see that the time to get the SUDS level down decreases, and the SUDS levels decrease over time. So in session 1, they're very high, and by session 4, these things don't necessarily cause so much anxiety anymore. So in terms of setting up a treatment plan, you want to generate a list of situations and thoughts that evoke anxiety and urges to neutralize, and then the patient rates each of these in their SUDS scale. And so collaboratively, you generate the exposure hierarchy as we discussed before, and then you want to make sure that the situations are realistically safe but will evoke obsessional distress. So you don't want somebody who's afraid of, jumping off of ledges. You wouldn't want to put them on the edge of like the Empire State Building, for example. That would not be safe. But you want to put them in situations where there's really not a huge amount of fear that something is going to happen. So the next phase is the gathering information phase. So you obtain information on OCD symptoms, history of the problem, you define the disorder for them, you explain it to them, you give the rationale for treatment, and you give the overview of the treatment program, what they should be expecting, and then you teach them how to monitor their symptoms using the SUDS scales, and you want to take a general medical history just to understand kind of If there are any other things that you should be, like if there was for example, I know an individual who had a TBI, and following the TBI developed a lot of these obsessive-like symptoms, and so there was a much stronger biological basis for this, and understanding that can help in the treatment as well. You then want to do an inspection of the patient's self-monitoring to make sure they're monitoring appropriately, identifying, appropriate situations and their responses to them. You want to get more information about the obsessions and compulsions. And then together you're going to be generating the treatment plan, how to select exposure situations, and then you want to develop a clear contract between the two of you to know what you can expect of one another. And then you want to teach them how to monitor their symptoms using different scales or using the SUD scale, and you'll give them a homework assignment. And so the treatment phase can be done, it's usually done over a shorter period of time. So rather than once a week, you're meeting multiple times a week for 2 hours. So you want to determine how you're going to format this for your client and what works in their schedule. So you're going to explain to them what they should expect, how the exposures will be implemented, and then they're going to be homework assignments where they have to continue these exposures between meetings. You want to talk about how they're going to comment during exposure sessions, and then doing response preventions in terms of the rules, how long they have to sit with it, and how they're going to return to normal behavior. Then you also want to discuss some things that might occur during session, like they're going to want to do their responses and how you're going to have to prevent them, and that they should plan with those kinds of things. So here's a sample hierarchy for somebody with contamination fear with a washing compulsion. So at the bottom, drink soda from a can without wiping it, use pens from the office lobby at an office, bring it in and open the mail, touch the floor at home, the hands flat, touch the floor at the office, hands flat, touch sidewalk, hands flat. So this hands flat might be kind of silly to you, but oftentimes people who have OCD will try to touch things with the very tips of their fingers, and this way the germs are theoretically getting all over their hands. You want them to wash for 30 seconds with no towel at the door, take out the trash, then eat dinner without washing their hands, touch several children at daycare, then touch things at home because now the home is being contaminated as well, go to bed without showering, and sleep with shoes in bed. So each person is going to have their own hierarchy, and this was the specific one for this individual. And here is a hierarchy for somebody who has doubting obsessions with a checking compulsion. So they're worried whether they, let's say, turn the stove off is their worst fear. So down at the bottom of the hierarchy, do not walk back to the car to check if it's locked. Stop looking at surrounding cars in the lot to make sure you didn't bump them. Do not reopen mail to be sent. Do not look in a mirror after leaving the house. Proofread email only once. Stop asking for reassurance from others. Check the locks once before leaving the house. Check appliances once before leaving the house. Check locks once before bed. Check appliances once before bed. So again, you can see they're still checking because these are normal behaviors, but they're not doing it in an obsessive kind of way. Here's a sample hierarchy for addressing exactness. So leave books askew on shelves, stack dishes incorrectly, leave clothing on the floor overnight, leave bed unmade, rearrange items on desk randomly, pull the gahar in the driveway crookedly, stretch right arm only, wear 2 slightly different socks, comb hair only 10 strokes on one side, 20 on the other, read aloud without rereading, and shave unevenly. So, even just reading some of these things make me anxious, and I really wouldn't consider myself having an order or symmetry thing. But we all have, different elements of this, and again, this is where it's becoming problematic in somebody's life. This is a slight variation. It's a sub-hierarchy for reading out loud. So if somebody has, various issues with reading out loud, you might do a sub-hierarchy. So read aloud without rereading, varying in tone, in session, varying in tone alone, in session. So there's varying in tone, intentionality. So you can see how those would vary across. If you have different things that you have to break it down, so one thing might not be sufficient, that there are various aspects or elements of it, you have to break it down into various pieces and expose the individual to each of those pieces. Here is a sample hierarchy for aggressive thoughts. Hold child in lap, spouse nearby, spend time playing with child, spouse in next room, imaginal exposure, slapping the child, spend time alone playing with child at home, play on sidewalk, near street with child, stand near window at a high floor with child, walk with child near the balcony at the mall. You imagine that you are stabbing the child. You use a small knife near the child and use a large chopping knife with the child nearby while allowing thoughts of stabbing the child. So again, you as a therapist would have to make sure that this is not a person who is psychotic, and you would make sure that this was a safe situation. But people who have OCD in this way do not often engage in these behaviors. Here is one person who has idiosyncratic or superstitious thoughts: order a different sandwich at a lunch place, do bedtime routine out of order, use the wrong staircase, park in an unusual place, wear your unlucky color, come in from a different door than you exit, don't call spouse on the way home, take an unlucky number of steps, and make intentional small mistakes in written work. So here's an example of an in vivo exposure for somebody who's a washer. So in session 1, they'd walk with a therapist through the building, touching doorknobs, holding each for several minutes, and they would not wash afterwards. You'd repeat the above thing and add contact with sweat by having patient touch armpit and inside of shoe. Repeat the above but introduce having the patient touch a toilet seat. Repeat the above but introduce urine by having patient hold a paper towel dampened with his own urine. Repeat above but introduce fecal material by having patient hold toilet paper slightly soiled with their own fecal material. And then you have them repeat daily exposures to the 3 most fear-provoking stimulus activities, and you have them repeated over and over again. So you can just see that this is not something that we normally do on a daily basis, but because this is so overwhelming for them, we have to have them exposed to their most feared situation. And if they can handle that and their anxiety decreases, then it doesn't, while OCD rarely goes away completely, it can be minimized to the point where it's not interfering in their daily lives, and these thoughts, using mindfulness can be minimized. So for a checker, in vivo exposure might look like session 1, turning the lights on and off once, turning the stove on and off once, closing the doors open and closing the doors once, and leaving the room immediately without checking. Session 2, you do the same thing, but then you add flushing the toilet without looking in the bowl. Session 3, you introduce opening the gate to the basement and closing it, allowing the daughter to play near the gate. Session 4, repeat but introduce carrying the daughter on the concrete floor. The 5th one is repeat above but introduce driving on a highway without retracting the route, because many times checkers will feel like they ran somebody over and they have to go back and check. And so sessions 6 to 15 require daily exposures to the 3 most fear-provoking activities, and these can be done on your own, or they may have to be done with a therapist as well. So rules for response prevention: patients are not permitted to use water on their body if they're washers. Bath powder and deodorants are permitted unless they reduce contamination concerns. So you have to assess that thoroughly, because if they reduce contamination concerns, you're just then causing avoidance of the feared stimuli. Shaving is done with electrical shaver. Supervised showers occur for 3 days for 10 minutes, so they can't overly wash. Ritualistic washing of certain areas of the body is prohibited. Family members must supervise adherence to the rules while the patient is at home, and violations are reported to the therapist. In the last few sessions, response prevention requirements are relaxed to permit normal washing. So you obviously can't stop somebody from washing for the rest of their lives, and they have to return to a normal behavior, but therapy is terminated when you feel like the anxiety is no longer at a level where it's impacting the individual's life, and then you can clinically make the judgment that they can kind of return to daily functioning. For a checker, there is no ritualistic checking is permitted. They can do 1 check, which is considered to be normal. You have a relative or friend who supervises this in the home, and a therapist or supervisor is to stay with the patient until the urge to check diminishes. So you don't want them to eventually go and check. They have to stay until they no longer have the urge to do so. And violations of home practice are reported to the therapist, and then they're worked through in session, and then subsequent sessions are overcome. So when you're constructing imaginal exposure scenes, they should be about 45 minutes in duration. They should have approximately 6 scenes of gradually increasing anxiety, and they should include both external and internal stimuli, both cognitive and physiological responses to the feared scene. So you'll have the person, thinking about, if somebody's afraid of getting cancer, so that the cancer is moving throughout their body, it is permeating every level of their cell, they're feeling the pain, they feel the warmth of the cancer kind of goes through their body, and you have them sit with that. Approximately 80% of people who complete therapy report beneficial effects, and up to 6 years following treatment, approximately 70% of the people will maintain their gains. So this is pretty astronomical for something that previously did not respond very well to intervention. But it's not a panacea. 18 studies of ERP were reviewed, and there's an 83% response rate at post-treatment. And at 9 months following, 76% of people still maintain their gains, and the mean symptom reduction at post-treatment was 46%. So while very, very significant, these things are still present to a certain degree, and this kind of supports my hypothesis that there's, or the evidence that there's a biological basis to it, and that, you know, treatment can help, you know, people maintain a normal lifestyle, but at the same time, these are going to be issues that the person is going to be struggling with, but they now have skills and tools to help them with. There are some limitations of ERP. There's a high treatment refusal and dropout rate. It's very hard to do this because these are people's, you know, weird things and they're exposing themselves to it. So it's difficult to do ERP in centers that do not specialize in OCD. So it's, you know, people have to have special training to deliver this type of treatment. Psychiatrists don't have a very strong supportive ERP. And a benefit is defined as a 30% decline in Y-box symptoms, which people are still obviously experiencing symptoms, but it's a decline. And it's very hard for people that suffer from primary obsessions and don't have necessarily compulsions, because they're, many times their neutralizations are mental, and it's hard to control things that are mentalized. I mean, it's very easy to physically stop somebody from doing something, but to say don't think about something is much, much harder. Cognitive therapy for OCD, I've already lectured you enough on this. I'm going to kind of skip through these slides. I'll post up the PowerPoint for this, so if you're interested, you can go through on your own and look at cognitive therapy for OCD. In terms of medication treatment, medication is often prescribed to go along with ERP. You can use SSRIs, tricyclics, and clomipramine, and neuroleptics like haloperidol, which is an antipsychotic medication. Generally, both medication and ERP are effective. But some studies find advantages for ERP over medication. So CBT or ERP is the choice for milder OCD. However, relapse rates are higher after withdrawal of medication than after cessation of ERP, as is the case with many of our other interventions, because we're teaching people skills that they can maintain rather than having the medication be the treatment. So overall studies do not support the combination of ERP and medication outperform either treatment alone. However, different people respond differently to interventions. And so some factors that may influence your decision to use medications with your therapy are the severity of the symptoms. If they're only having partial response to the ERP, you might have to include medications. If there's a high degree of comorbidity between other disorders, like a high degree of depression or other anxiety disorders, and if people are just unwilling to tolerate the distress of ERP, they may have to take medications to minimize their symptoms. So now we'll talk about generalized anxiety disorder, or GAD. So worry has been experimentally demonstrated to prevent emotional processing, and thus may maintain any disorder wherein such processing is important for therapeutic change. So once somebody has received successful treatment for GAD, there are huge declines in comorbid symptoms. So GAD is when a person is worried for 6 months or more about a variety of issues, and that worry is you're spending more than 50% of the day, more than half the days of the week, worrying about these things. And these things are generally, they may be realistic, but the worries seem to be out of proportion to the degree to which they are realistic. Many times when people say they're stressed out, this could be, symptomatic of GAD. However, GAD, the duration must be 6 months or longer. So people who have GAD or a lot of worry tend to find ambiguous situations threatening. They have an elevated estimation of risk. They tend to generate negative scenarios in ambiguous situations. A nice example of this is something that I do. Again, we all have I think I'm telling you all about my own psychopathology, but we all have symptoms of all of these disorders. But I remember several years ago, I was expecting a friend, and she didn't arrive on time, and I couldn't reach her by phone. And immediately I had this scenario that she was in a car accident, and I called the hospital, which was very much out of proportion to the situation in itself. And obviously later on I thought it was kind of a nutcase, but it was definitely something I was thinking about. I don't know why these slides are doing this right now, so forgive me. But the impact on GAD on healthcare utilization, it's the most prevalent anxiety disorder found in primary care settings. GAD patients are twice as likely to seek treatment in primary care as opposed to psychiatric treatment, because people tend not to see, being stressed out or worried as a psychiatric condition, but rather as a condition of daily living these days. And then among patients classified high in medical care utilization, 40% meet lifetime history of GAD and 22% meet current GAD diagnosis. So people who you go to the doctor a lot, who are seeking medical treatment, many of them do have these worries. And we know that in addition to the symptoms that the worry creates a bunch of other symptoms and other disorders. And so, people with GAD, in addition to having worry, might have a host of other physiological symptoms. So in terms of assessing worry, some of the questionnaires that you can use are the Penn State Worry Questionnaire, the Beck Anxiety Inventory, and the SUD scale that we've already talked about. People with GAD, as I said, worry about a number of different things. Primarily, the majority of them worry about family, followed by money, work, and illness. Now, here's how we differentiate GAD worry from normal worry. Patients with GAD are worrying over 300 minutes per day, whereas the average person is worrying kind of more like an hour a day. So we all worry, that's normal. So worrying about an hour a day, interspersed is perfectly normal. But when you're spending, 5 hours a day worrying, that is very disproportional, and you can see there's a huge difference between those with a diagnosis and those with not. So there's been kind of a lag in the development of psychotherapy for GAD as compared to other anxiety disorders, and I think part of that is because the disorder is much more diffuse, and it's also considered to be somewhat more normal. Like you commonly hear, oh, I'm feeling stressed out. And so I think people have not viewed this as pathological as it probably is. Early treatment research on GAD focused on somatic anxious experience and used relaxation to provide a more generalizable coping response to stress and anxiety, and even current treatments will involve the use of relaxation. So in CBT for GAD, gotta love those acronyms, you're doing the self-monitoring, noticing situations that are causing the stress, anxiety, notice how often that you're doing it, notice what the thoughts that are going along with it. You then do cognitive restructuring, applied relaxation, which is your blog exercise number 3, coping and desensitization, so you work with them on coping, and then worry exposure, where you actually have them expose themselves to the worry situation. So currently, in terms of our research on GAD, as I said, we're lagging behind, but CBT is associated with low dropout rates and reductions in medication taking. Xanax is not an answer, and people who go off Xanax often have relapses very quickly. However, at best, only about 50% of patients achieve recovery status, although we can minimize symptoms in many of the other patients. So currently, it's still, one of our frontline interventions, and I would encourage you to use CBT techniques. But again, it's not a panacea, and you should, let your patients kind of know this in a more hopeful and optimistic kind of way. So we know that both pharmacological therapies and CBT lead to marked improvement in GAD symptoms in the short term. But the effects of CBT are more durable than pharmacotherapy once treatment is discontinued, and CBT is associated with low dropout rates and reduction in medication taking, which to me seems beneficial. And we're going to finish off with PTSD. Of all the anxiety disorders, PTSD is probably one of the most severe. But with good treatment, the results are actually quite promising. Characteristics of PTSD include intense reliving of traumatic experiences, re-experiencing through intrusive thoughts, nightmares, flashbacks, psychological numbing and avoidance, symptoms of hyperarousal or physical dysregulation, and comorbid with all of these symptoms of PTSD are symptoms of anxiety and depression. So what we typically think of with when we say PTSD is we think of people who are victims of a sexual assault, generally a one-time assault, as well as people who are combat veterans. We're seeing a lot of PTSD in our veterans coming back, from wars. We saw it in Vietnam. We're seeing it now with the Iran, Iraq, Afghanistan wars. And so we do have treatments that can be effective in coping with some of these symptoms. But people have PTSD reactions to a lot of other circumstances, and it becomes a little more challenging because, people who have chronic, abuse, there's not one particular situation, but rather, a lifetime sometimes of abuse that it can contribute to it as well. In 97% of patients, once they develop PTSD, it becomes chronic until it's treated. Until treatment is received, most people with PTSD suffer for about 8.7 years, which is a great amount of time. About half of them are taking some sort of psychiatric medication when they come to treatment, usually mid to late 30s and 75% female. Men often don't seek treatment for PTSD. Again, I think gender stereotypes, they feel like they should be able to handle it. But we know that this is something that's kind of beyond handling it. 65% of people who have PTSD have multiple traumatic experiences, such as sexual abuse, physical abuse, accidents, death of significant others, such as murder, and war exposure. So when you're doing a CBT intervention, there are several things that you want to start out with, which are the same as many of the other ones. Assessing the patient's safety. So you want to assess for suicide risk because there's a higher degree of suicide among patients with PTSD. We're seeing this a lot on our military bases right now. There's a tremendous amount of suicide. I forgot the statistics exactly, but I want to, I could be wrong. I want to say it's something like one person per day. But it was very mind-boggling when I heard about it, and it was very tragic, honestly. You want to look at the patient's goals. You want to educate them about their disorder and about the treatment. You want to work with them on tolerating distress, mastery and pleasure exercises, because many people who come to you with PTSD also then have comorbid depression. You do some cognitive restructuring. Then you start with the exposure, first imaginal and then in vivo where applicable, and then relapse prevention. Edna Foa is really, out of the University of Pennsylvania, is really the pioneer in the area of exposure therapy for PTSD. And then Patty Resnick, who was at the Boston VA and I believe is now in, I want to say, South Carolina, I could be mistaken, but she has kind of also done a lot of work with trauma and is working a lot with the Veterans Association. So the goal of imaginal and live exposure is to modify dysfunctional beliefs. So what happens when people experience these intense traumas is we tend to avoid thinking about them because they're so emotionally painful that we can't cope. And as a consequence, we've not emotionally processed this trauma. And it becomes this kind of like, if you want to think about the id, it's like, this beast that's kind of rearing its ugly head, and you get all these symptoms like the re-experiencing it, the dreams, the nightmares, the flashbacks, because we try to push it down. And it's not until we actually deal with it and kind of let it come to the surface and cope with it and feel the emotions and process this that we're able to kind of move on. That doesn't mean it's going to be okay. Like, it's not okay to watch your best friend's head blown off beside you. You're not going to be ever okay after that. But it's not going to be something that's, kind of keeping you paralyzed and from moving forward with your life. You want people to write out about what happened, about the trauma, and reread it so they become habituated to it. Talk about the meaning of the event. So what does that mean for them? Because for many people, this ruins their perception that the world is a safe place as a consequence, and this has really kind of shattered this belief for them. You do exposures to distressing but safe situations. And then you help interpret, some of the fears that these people have, like the boundaries between safety and danger, issues of trust, power, competence. So you have to make them feel like it's okay to live in the world, again, even if the world might be a more dangerous place than they initially thought about. Some of the beliefs about trauma, useful things they learned from terrible events, jaded, cynical beliefs. They want to talk about the boundaries between safety and danger. So, we want to estimate risk. So even if you may have been in a plane crash, the risk that will happen again is very low. That there are many things that are predictable and controllable, but many things are beyond our control, and we kind of have to live our lives accepting that and putting power and trust in other people sometimes. In terms of self-concept, not blaming yourself, and then the hindsight bias, we tend to overestimate the probability that something will happen once we have outcome information, and so kind of adjusting, understanding that, kind of like if you think about the sexual abuse at Penn State, everybody, after the fact came out, you said, like, why didn't people know? Why didn't they identify this stuff? If I would have seen that happening, I would have done something. And hindsight is 20/20, and so, but in the situation, before you have the outcome information that he was molesting the children, a lot of these behaviors can be interpreted differently. So this is a description of an exposure-based treatment for rape, described by Foa and her colleagues. So I'm going to ask you to recall the details of the assault. It's best for you to close your eyes so you won't be distracted. I'm going to ask you to recall these painful memories as vividly as possible. We call this reliving. I don't want you to tell a story about the assault in the past tense. Rather, I'd like you to describe the assault in the present tense as if it was happening to you right now. I'd like you to close your eyes and tell me what happened during the assault in as much detail as you remember. This includes details about the surroundings, your activities, the perpetrator's activities, how you felt, including your physiological responses like your heart beating faster, what your thoughts were during the assault. If you start to feel uncomfortable and you want to run away or avoid it by leaving the image, I will help you stay with it. So you can see how tremendously painful this would be for somebody who has worked there, since the trauma, to avoid thinking about it. This is very, very painful, and so it's very difficult, and it takes a very skilled treatment provider to do it. And again, these are sessions that don't necessarily last only 50 minutes. They might, last several hours at a time, and you have to be prepared for that when you book the session. Now, again, with technology, and we can do virtual exposures, so you can kind of program in the same scenario. They're doing this a lot at the VA, as you can see, in combat situations. And so we use virtual reality to re-experience the combat trauma. It's multisensory in that, there's auditory, visual, sometimes you can even do smell. It uses Xbox technology, and it's found to significantly reduce PTSD symptoms. So there's a lot of promising stuff out there available with technology. So the effectiveness of rape trauma treatment, this is FOA's work. In 9 biweekly 90-minute sessions, they resulted in increased organization of rape memory, increased narrative length and detail of memory, increased emotions and thoughts about rape, reduction in trauma-related symptoms, and reduction in depression correlated with meaning-making. So we're seeing, the patients can actually remember details of the event now, but that overall they're able to handle it better, and their symptoms of depression and PTSD